Ladies and gentlemen, we are live now, and thank you for your patience. So hello everyone out there, our listeners and our viewers. Welcome to the second edition of our Ethics Compass. Today we shall be talking about medical ethics and the patient's bill of rights. I will begin by introducing our guest speakers. The first person I want to introduce is Dr. Aloysius Ochasi, who is a professor of bioethics at St. Joseph's University in Philadelphia. Dr. Ochasi, you're welcome.
Thank you.
I want to also introduce Dr. Njideka Okonjo-Dochie, who is the Chief Executive Officer of Summit Medical Group here in Maryland, and also one of the best doctor in Maryland for the past 3-4 years now. Dr. Udochie, you're welcome.
Thank you.
And I want to introduce Dr. Iheanacho Charity, who is the Assistant Director of Medical Laboratory Services, Jos University Teaching Hospital. Dr. Iheanacho, you're welcome.
Yes, thank you very much. Good afternoon.
Thank you, everybody. You can see that we have competent hands here today from across the world. The good thing about this conversation today is that our speakers are all Nigerians. Most of them started out from Nigeria, and they still have strong contacts in Nigeria. Some others are also practicing in Nigeria. We are going to be talking about an issue that is very important in healthcare, and that is the issue of patients' bill of rights. I would begin right away by reaching out to Dr. Ochasi, who is a bioethicist, to talk to us about patient's bill of rights. What is it? How did we come about it? Can you define it for us and what it's all about? Dr. Ochasi.
Hello, everyone, and hello to my co-panelists, Dr. Udochie and Dr. Iheanacho. And thank you, Father Gatto, for putting this together. Going to start with some kind of historical context. History is super important. My favorite Roman philosopher, Cicero, said that it is good for the past to be made present so that the future will not be stillborn. So we need to have a historical overview of how we got here vis-a-vis medical ethics. So I'm going to start on the global level and kind of come down to our Nigerian situation. So the history of medicine from the Hippocratic physicians has been dominated by what is known as paternalism. So paternalism is from the Latin word pater, P-A-T-E-R, which literally means father. So it means father knows best. So think of it this way: growing up and your father wants you to do something, and then you're asking, why should I do it? And he simply says, because I'm your father. There is no justification, no rationale, just because I'm your father. So in medicine, medical paternalism simply means the doctor knows best. The doctor knows it all, right? So it's more like if the doctor asks you to jump, you really don't ask, doctor, why should I jump? You ask, how high do you want me to jump? That's medical paternalism. So that has dominated the history of medicine from the time of the Hippocratic physicians, more than 2,500 years ago, until last century, when paternalism was challenged. And paternalism was challenged by what is known as informed consent. And I'm going to trace two areas how it came about. So first of all, there were abuses in medical practice, especially here in the United States where I practice. And the very first time, paternalism was challenged was in 1914. A woman went to the hospital, New York hospital, and the doctors wanted to examine her. She had problems with her stomach. And she said, yes, I'm going to agree to examination under anesthesia, but on no condition whatsoever do I want you to operate on me. So she did not consent to surgery. They put her under anesthesia and ended up operating on her. So when she woke up from the effects of anesthesia, she was really very angry and then sued the hospital and then won the case. That was the very first time an individual challenged physicians and won that case, 1914. The second case was in 1957. It was a case of someone who went to the hospital, was having problems, with his lower extremities. He was having circulation problems. And the doctors told him of all the great things they would do to make him feel better, but no one told him about the complications or the risks that might emerge from, the procedure. So he consented to the procedure, but the following morning, he couldn't stand up from his bed. He was paralyzed from the waist down. He also sued the hospital and then won the case. He won the case on the grounds that they did not tell him about the risks of the procedure, right? So these two cases from the medical practice challenged paternalism. Now, on the biomedical arena research, right? If we all remember what happened during the Second World War with the Nazi physicians, a good number of the doctors who took the Hippocratic Oath to do no harm did so many crazy, inhumane things with prisoners, with Jews, gays, gypsies, and people they considered misfits, right? They were operating on twins, conjoined twins, injecting poisons into people, doing all sorts of crazy things with human beings without their consent. Now, at the end of the war in 1947, a group of American generals flew into Germany, Nuremberg, Germany, and then tried these doctors. I mean, these were not soldiers, these were doctors doing this with human beings. And then tried these doctors, some of them were sentenced to death, some were also sentenced to life imprisonment. But the great thing that emerged from there was a code emerged, an ethical code emerged. And then they named the ethical code after the city where these trials took place. It took place in Nuremberg, Germany, and then they named it the Nuremberg Code. That was the very first ethical code we got vis-a-vis, research. And then the Nuremberg Code says the voluntary consent of every human research subject is absolutely essential. This was in 1947. Fast forward in 1964, the World Medical Association also reaffirmed that, right? That's happened in Europe. But in the United States, between 1932 and then 1972, over a 40-year period, something was going on. So many of you also may have read that the Tuskegee syphilis experiment. Now, the United States government wanted to know the natural progression of syphilis. They were not trying to develop a vaccine. They just wanted to know how long does syphilis stay in the body of a human being before the person dies. What did they do? They went to a very poor part of this country, Macomb County, Alabama, and then recruited about 600 African Americans, Black men. 399 of them were in the experiment, 201 were in the control group. They lied to these people. They told them they had bad blood, and they made all sorts of promises to them. We're going to give you free meals, free burial insurance, and all those things. No one ever told them that they were trying to study the natural progression of syphilis. This happened for a 40-year period. It started in 1932. By 1947, penicillin was discovered. So with few shots of penicillin, this man could have been cured of syphilis, but no one even gave them the penicillin, right? Until 1972, when a whistleblower said, I can't continue to have this on my conscience, and leaked this experiment to the New York Times. And when it was leaked, there was this huge public outcry. And then people were saying, we can't continue this way. So between 1974 and then 1978, 10 people worked on how to develop or articulate ethical principles that should protect individuals, human beings in research. So they came up with what they call the Belmont Report. So Walt Belmont was the room they were staying to do this in the Smithsonian, right? So they came up with 3 ethical principles. Number 1 is what they call respect for persons. So the medical ethics we know today, especially the principles, the prima facie principles we know today came from this Belmont Report. And so you have autonomy, which is the same thing as respect for persons, which is also human dignity. It's almost like number 1. You have number 2, which is beneficence, which means whatever you're doing in a hospital system must benefit the patient. Beneficence comes from the Latin word bene, which means good, okay? Whatever you do must be in the best interest of the patient. Number 3 is non-maleficence, do no harm, which dates all the way back to the Hippocratic physician. And then number 4 is justice, treat like cases alike, treat people fairly, okay? So these are the famous or the paramount ethical principles, we have today in medical ethics. So this is how, medical ethics came about per se. So this is on the global level. Let's come back to the Nigerian situation. My impression is I have downloaded this Bill of Rights and reviewed the 12 Bill of Rights. I think from my experience as a Nigerian, I think we're still operating in the era of paternalism on so many fronts, right? Looking at the Bill of Rights, what I see on paper is great. It's excellent. I mean, they did so many great things articulating these Bill of Rights. Billion naira question becomes, are these things being operational? Are these things being implemented? That is what I think our discussion today will be about, right? And my goal in this conversation is to empower people out there. When you're empowered, you're able to empower other people. When you're empowered, you're able to advocate for your rights and the rights of your fellow citizens. So I'm going to stop here so far and then see what my co-panelists think about.
Okay, thank you, Dr. Ochasi, for that very erudite presentation of the history of medical ethics in healthcare industry, and again, taking it down to Nigeria. Are you aware when this medical law, medical ethics came on board in Nigeria? Has it been part of the practice all this while? Can you shed some light on the history of medical ethics in Nigeria, Dr. Ochasi?
Right, so I would say the Bill of Rights just came on board like 5 years ago, right? I did some research and realized, that it came on board like 5 years ago. But my impression is there are good doctors out there. There are doctors who respect their patients each and every day in Nigeria. There are doctors who are ethical physicians. There are doctors who are doing the right things. But also, on the other hand, there are people who just take advantage of patients. There are doctors who are just out there to make money.
Thank you, Dr. Ochasi. I'll just hold it there. I go to Dr. Njideka Udochi. You're a Nigerian. You studied at the University of Nigeria in Nsukka, right? And you were practicing as a doctor in Nigeria before you moved to the United States, correct?
That's correct.
Okay, so when you were practicing in Nigeria before you moved to the United States, did you have anything like medical ethics? Did you have anything like Bill of Rights as a doctor?
As a matter of fact, thank you very much, and good morning, everyone who is listening from the United States, and good afternoon, everyone. And thank you to Dr. Ochasi and Dr. Iheanacho for joining us to discuss this very important issue. Yes, I did practice. I trained at the University of Nigeria, Enugu campus, and before you complete your training, we did get a class on ethics, medical ethics. We all swore to the Hippocratic Oath, and I did practice in Enugu before leaving for the United States. And the question of, patient Bill of Rights was not something that was really discussed during a medical training. And I think that it's something that is really, like Dr. Ochasi said, it's something that's just been instituted in Nigeria in the past year. I think Vice President Oshibajo launched it in July of 2018. But over here in the United States, right, every state, every hospital has, must abide by the Bill of Rights. And like Dr. Ochasi said, we're looking at what we have in Nigeria. The 12 different aspects of it are very, very good, very important, and actually tally with the Bill of Rights that you see in Western countries and here in the United States also. And he has already gone over in great detail about what should be included. The fact that you have autonomy, you have to get consent from the patient, you have to do what is right for the patient, and you have to do no harm. I think that using these three guiding principles, if you look at what we have in the 12 different aspects of our Bill of Rights for Nigeria, it meets that criteria. And like Dr. Ochasi had already alluded earlier, it's not the question of, are these Bill of Rights important? Are they something that we should have in Nigeria? Everybody agrees when you read them, and it's available online for everyone to see. Everyone will agree that this is something that we all need and something that should guide the practice of medicine in Nigeria. The question is enforcement.
Okay. Okay, so, Dr. Udochi, thank you. Thank you, Dr. Udochi. I have to jump over to Dr. Iheanacho, who is on ground in Nigeria right now. And Dr. Iheanacho, can you tell us the situation of things, the status of Patients' Bill of Rights in Nigeria? We understand that this was, introduced 5 years ago, and it was launched by Professor Osibanjo. So what is it now? What's the awareness like now? Is it something that is very common, is very popular? Doctors, nurses, everybody, all of them are aware of it. Dr. Iheanacho.
Okay, thank you very much, and good afternoon, the listeners, and of course, the umpires of this program. I'm really grateful. For Nigeria, yes, it has been launched by the Vice President, Professor Yemi Osibanjo. And for now, we even have what we call Servicom in every hospital desk, usually positioned right from the entrance of the hospitals, at least the teaching hospitals are where we are operating, and even some of the privates. But as per whether the patients, because you can just pass the desk and have this, there's a desk and always staff on it, and it's boldly written Servicom. And usually that desk is supposed to help the patient's rights, protect the patient's rights, and then inform them. But of course, as you can see, it's not usually done that way. Because somebody is coming in the hospital, maybe coming in emergency cases, he will not go around and go and be looking for Servicom and things like that. And I guess in our hospitals, we are somehow overwhelmed that usually when patients come, nobody even goes around to inform them. So most of them do not know this issue of patients' right. And in our own hospitals, I guess perhaps because of overworking, the various professions of the hospital, we do know this Bill of Rights of the patient is well taught in every profession: nursing, medical lab, pharmacy, even the medicine and surgery is well taught. But the problem is the application in the hospitals, because it's one thing to learn the theory, but it's another thing to start the practical when the music starts playing.
Okay, so thank you, Dr. Iheanacho. That's a very good submission and intervention there. Now we have gotten a general view of Patients' Bill of Rights, medical ethics in Nigeria globally, and now I want us to go down to the specifics. You know, myself, I'm a Nigerian. I'm always in Nigeria. I go back and forth between Nigeria and the United States. And I have had my own experiences with medical ethics in Nigeria. And I want to focus on some of the controversial, some of the most important issues that Nigerians face when it comes to medical healthcare and medical ethics. The first one I want us to talk about is emergency care. Emergency care. Yeah, I have heard severally from people that when they are rushed to the hospital, some doctors do not accept them, do not take them in, do not treat them. In fact, still as we're speaking, even as we speak now, some hospitals do not accept people who were involved in maybe in accidents. Some don't take patients that have gunshot wounds or injuries. And I remember there was a time it was an issue in the National Assembly, and there was a law passed against it that patients must be accepted by doctors and all that stuff. What is going on here? Should doctors and hospitals reject patients that are rushed into their hospital or not? I'll go right straight to Dr. Aloysius Ochasi, and quickly, can you speak to this?
Thank you. And my short answer to that question is no. It is unethical for physicians to refuse to treat patients in an emergency situation just because of financial considerations. It goes contrary to what that profession represents. Physicians are in the business of saving lives. So if you're beginning to, equiparate someone's life, with maybe paying 50,000 naira, card or whatever, and then you let someone die before you, it is a violation of that oath, do no harm. It is a violation of what that profession stands for. And then I will also go to the next level that we need to begin to codify these things, where, most of us practice here in the United States, they do have a law that obligates every hospital, every emergency hospital to stabilize people who come into the emergency with or without the ability to pay. And it is called EMTALA. So EMTALA is EMTALA, stands for Emergency Medical and Active Labor Act, right? So basically anyone who shows up in the emergency, you must treat and stabilize. Talk about the money later. So letting someone die before you is just a gross violation, of what we know ethically vis-a-vis medical profession.
Dr. Iheanacho, correct me if I'm wrong here. Is it still the practice that some hospitals still reject patients that come in for emergency treatment? What is the practice in your hospital at the University of Jos Teaching Hospital where you are working?
Well, in my hospital, we do not necessarily reject patients because of inability to pay. What happens is those cases that come in like gunshots or some cases like that, they will say that they have to have a police report or a police extract. And that's usually what delays the treatment, because some of them will come in without any police accompanying them, no security personnel. And the hospital will say, or the nurses in the emergency unit will say, well, they have to have a police extract or have a police, so that this case will be covered. And so it's not necessarily, though with this issue of health in the box that we are having now, is another problem that we are having, that, okay, if they don't pay, you generate the NR and they are not able to pay, so to register them in. But still, even now, we are still trying to, combat that. So sometimes under their emergencies, we do treat the patients, but is this issue of gunshots or kidnap cases or rapes, and they say, no, you have to have a medical, a police extract.
But why would they have to? Why would they have to have a police paper? And has this not been discussed in the National Assembly? What is the law about it? I think there is a law about this in the country. And why are the hospitals not following the law?
Well, you see, sometimes the laws are made there, but the problem is in the bed where this patient dies. Now, you do not have a police backing to say that, yes, they cannot claim that it was actually the hospital carelessness that killed the patient. So somehow the hospital management is also trying to hide their faces so that you do not push on their brains that was not actually their own. So that's usually the dicing issue in these cases. But usually when this comes up, we can always phone like the Chairman Medical Advisory Committee or the CMD. And once he's able to give his go ahead, then fine, you go on and treat the patient. Usually these things will be handled by phone calls and so on. So they don't usually keep patients because they are not able to pay all this. But as I said, police extract.
Yeah, and we want to talk about this police document and whatever, because this is serious. We're talking about life here. And we are talking about paper, police paper. That is the reason why we cannot save life. I mean, that sounds totally ridiculous to me. And we need to see what is going on here. Why is this an issue? Why is it that medical doctors in Nigeria have not engaged the law? Why is it that there's no solution to this problem? Because I can't get it. Honestly, I can't get it. That somebody is dying in a pool of blood and we're saying we can't treat him because we cannot get a police report. Well, I turn over to Dr. Njide. Was this the practice when you were in Nigeria? And what do you think about it?
Well, I mean, this was not the practice when I was in Nigeria, but there's been a lot of change because remember that was in the 80s and early 90s. So obviously it sounds very ridiculous to say that somebody's dying and you're not able to render any care because they don't have a police report. But what Dr. Iheanacho is saying, you have to look at the whole country and the way the practice of medicine is. I think that it's really important to emphasize the fact that we don't really have strong enforcement in all aspects of the country. So you have the Nigerian Medical Association. The doctors are supposed to abide by a certain code of ethics. They're supposed to render care to patients. They know that they're supposed to do that. But the problem is that even if they don't, nothing happens to them. You don't have lawsuits, that go into place. There's no consequence to their medical license or to the license of the hospitals. So like Dr. Ochasi said earlier, it's more of a paternalistic approach to the practice of medicine because, rules and regulations are not enforced in Nigeria. We don't have a strong enforcement arm. So hospitals tend to make up their own rules and regulations. We know that it is in practical terms, when there's a gunshot wound or, like Dr. Iheanacho said, in situations maybe where there's a rape, most people don't even have the time, to get a letter or get a report from the police. Their family members are bringing the patient and bringing him straight into the hospital. What should really happen is that urgent care and emergency care should be administered to stabilize that patient. And once the patient is stable, then you can move on to the next question of where is this report, But the fact that nothing is done to save the life of that patient is not ethical, Yeah. So I think that's where, we need to work on that, to ensure that the hospitals at least begin to provide that emergency care to stabilize the patient. And have we also stratified the hospitals in Nigeria? Which one? They might be in a hospital that doesn't have the equipment to do that. We know that we don't have a strict, good quality care in some of the hospitals. A hospital may not have the personnel. They might not have, the proper equipment to help that patient. Okay, and the patient is in their emergency room.
Okay.
That
Okay,
what
Dr. Njideka, hold it right there. And I mean, you provide a very good, background here, and you are a bridge. You're a bridge. You're a Nigerian. You practice in Nigeria. You're now in the United States. You're practicing in the United States. How did Americans resolve this issue? Here, people are shot every day in Baltimore. You know that. The gangs in downtown Baltimore shoot people every day, and they rush them to Sinai Hospital or some other hospitals. Do they ask for police report? How has the system, you've worked in the hospital here, you've worked at St. Agnes and several other hospitals, you've worked in trauma level hospitals. How did America solve this problem? What are the problems involved here? What are the issues here? Why would doctors have to wait for police report? People are raped here also. People are shot here also. People get into so many criminal offenses that lead to medical care. How did they solve this problem, and what can Nigerians learn from America when it comes to emergency treatment that involve gunshot wounds, rape, and anything that has to do with the police?
Yes. Thank you, Father Godswill. Here in the United States, of course, there's a very strong enforcement code, and the hospitals are stratified, so you know which hospital is a trauma center and which one is not. But immediately a patient comes into any hospital, what we have been talking about in terms of what you need to do to save that patient's life is the most important thing. So here, emergent care is rendered to stabilize that patient. If that particular hospital does not have the equipment or the staffing to handle that patient will be medevaced by helicopter to the nearest trauma center. The doctors that will call to that hospital to say, we have this patient here, this is what is going on. They give a report to that hospital, that patient is flown there. It is after that patient is really out of, the emergency, condition and is stabilized that you start asking about police report and things like that. It's not the primary responsibility of somebody who is dying or who is in a really critical position to be, or the family members even, or friends or whoever brought them, to now start providing that information. It is until that happens that we do that. So it doesn't matter whether you are actually the person committing a crime, whether you're the person who is, who has suffered from this crime, we're all required to treat everybody the same and to make sure that we are providing urgent care. But
okay, Dr. Njide, wait a minute. So there was an issue that Dr. Iheanacho also raised. Assuming the patient dies here and the patient did not come with medical police reports or anything, how far would the hospital get into trouble with the police for that?
So that's what I think that Dr. Otasi also mentioned about the fact that there are other rules that govern emergency care in the United States. And actually, hospitals here, especially in Baltimore, receive a percentage of money, an additional, let's call it like a grant that they get every hospital to help support this kind of care. And that is something that we don't have in Nigeria. So even though we're saying, okay, all the patients here receive that care, the government, the state government, the federal government, they're allowing each of the hospitals to receive a certain percentage of money every month. That money is monies that we use towards providing that emergent care, especially in cases where people don't have the money or the ability to pay. So that's what helps the hospital.
Okay, thank you, Dr. Njide. I'll go to Dr. Ochasi right now. There is an issue that I'm pursuing here, and I want us to deal with this issue. Dr. Iheanacho was quite clear that payment is no longer an issue as much as the police problem that goes with people that come to rush the hospital for crime or gunshots or everything. And she was very clear. She said, why sometimes they don't accept the patient is because maybe if the patient dies in the course of treatment, that the police will come after them and say they killed the patient. Right. And I'm just trying to understand there must have been a way to deal with this matter that Nigerians have not yet figured out. Dr. Ochasi, can you jump in here?
Right. So without seeing the specific law you were referring to that was passed, regarding this, I think, there is a difference between law and ethics. Ethics is about what is right and wrong, right? Sometimes the law is black and white, but ethics has so many areas. So this law has to, have both civil and then criminal, immunity for physicians. Who knows, these doctors are also trying to protect their behind, right? They really don't want to get into trouble, but that is no justification whatsoever for letting people die under your. So one, if this law has inbuilt civil and criminal immunity for physicians, then they won't have to worry about, someone coming out after them to sue them for negligence. If it doesn't have that, we should also be advocating, because that's also one thing. We'll know what is right, but we also need to advocate what is right in this situation. So does it have inbuilt immunity for clinicians and hospitals, who care for patients, right? If it does, then the next thing should be negligence. If physicians are safely and criminally protected, and then they don't care, they don't treat these patients who come into their ED, then they're negligent, right? In that case, families can also come after them and say, well, you were protected by the law, but you did nothing, and then my loved one passed away. So whether the person is a criminal, a rapist, a terrorist, it still doesn't make them less human. Again, this is ethics. They're still human beings with human dignity. Their crimes do not in any way define them. So we do have an obligation to stabilize, first of all, before we begin to talk about police report and then going to jail and then going to court.
Okay, thank you, Dr. Ochasi. I'll go back to Dr. Iheanacho. Are you conversant with the law of gunshot, the law about gunshot? And are doctors and physicians and providers, do they have immunity when it comes to what you're talking about? Does the law provide security for the doctor? So let's say somebody is rushed to the hospital on gunshot wounds, and then the person dies in your hospital. Are the doctors and hospitals not protected? Would the police come and arrest the doctor, the MD, or the hospitals? I'm sure that the Nigerian legislators must have taken care of this in the law. And if this was not taken care of in the law, what are doctors in Nigeria doing about it?
Okay, thank you very much. Yes, the law did take care of that.
Okay.
But the problem we have in Nigeria, of course, you said you're a Nigerian, and I'm sure you understand Nigeria very well. Sometimes you don't come out rightly to say certain things. Now, we have a case. Let's just paint this scenario we have talked about. Somebody comes in with a gunshot. And most of our hospitals are not properly equipped. The tertiary institutions, if you remember that we have been going on incessant strikes in the health system. And most of these strikes were because the hospitals are not. You talk about ordinary scanning. A patient comes in like that and you need to scan him. You know that, like, okay, let's assume, like in my own hospital now, we have just one scanning, that's in the radiology system. You have to carry this patient down there. And then most of the time, the light is not stable. And there is no report. And the doctor to stick out his head. Then the next moment, before they finish going to, the radiology, come back and they tell you that the scanning machine is not working. Most of the time, our MRI machine. So that is why most of the time we cannot take care of these emergency cases because of the inadequacy of, instrumentalization in the hospitals. Most of the laws have been made. Yes, we have a law to protect, patients' rights and all that, but we are not properly equipped. Again, understaffing is a problem. So there are a lot of complications in the Nigerian health system. So we have to count one before we can count the 3 and 4. And that is why our advocacy is that, just like Dr. Udochi said, in the US, the hospitals are stratified, but it's not so in Nigeria. Hospitals are not stratified. Everybody seems to be doing everything and cannot even do everything. The highest hospital we have is the tertiary institution. That's the teaching hospitals. They are the highest government hospitals we have. And most of them, as she can tell you, when she was in UNTH, most of the equipments are always down, especially the radiology system. The laboratories are not properly equipped. So how do we handle and make sure that patients' rights are well protected and given optimum treatment? So we have a lot of cases fighting against human and patients' rights in the hospital.
Okay, thank you, Dr. Iheanacho, for that insight. I mean, there are a couple of issues here, but I think we have come to an agreement that yes, the law protects doctors, nurses, and medical and healthcare providers from any blemishes or anything, lawsuits or arrest for taking care of people that have been, gunshot patients and everything, wounds and everything. But maybe the problem is that you guys do not have the adequate facilities to take care of this, and that could be the reason why doctors reject and hospitals reject patients in this situation. But then the question then is, the next thing is that, what do we do about this? Are we going to continue to be in this situation? Are we going to continue to reject patients when they come because we don't have the facilities? What are you people doing about it? We strategically got you on board because you are in one of the apex hospitals in Nigeria, government hospital, federal hospital, teaching hospital. So if they can't help, who else can help? We have healthcare insurance in Nigeria, and I think that insurance should be able to help you guys provide as much equipment as you need to do your work. So is that helping? Or are there other moves that you people are making to ensure that you have adequate facilities? In that way, we don't have to turn people that are almost dying away when they come to your hospitals.
Well, I don't know to which level the healthcare insurance scheme is helping. I know that we have a healthcare insurance scheme right in the hospital where I'm working. The only thing they do, okay, patients, the patients come in and then they don't pay. Certain services they don't pay, while certain services they pay like 10% of it. But those services now, whether the patients are going to pay 10% or they are not paying at all, if the hospital does not have the facility, they are usually turned to go outside to maybe some private hospitals or so. But the issue of equipping the hospital, honestly, we have been crying, we have been writing to the management and all what. As you can see, we have even gone on strike sometimes because of it. And up till now, most of these things are not being met. So sometimes in the night, a patient comes, an ordinary, maybe you and E-creatinine test, the machine has broken down. And around 12 midnight, the patient has to be sent away. Or maybe he has, and then there's no transfer. So it's a big problem. Now you talk about.
Okay, I know we can't solve all that problem today, but let's jump over to something else around medical ethics. I want to talk about the consent and the issue that most Nigerians have complained about. Medical doctors in Nigeria, some of them, they write prescriptions for you, but they don't even tell the patient about the prescription. It has happened to me before, and it has happened to me when my mother was sick years ago, and we took my mother to a local hospital. And then even to get the doctor that night was crazy. We kept calling and calling. The doctor said they should not call him after 10 p.m. I'm like, what are you talking about? And eventually, when I had to put all the pressure on the nurse, he called the doctor, and then the doctor told her what prescriptions to give to my mom. I was asking the nurse, what is the medication about? What is it? Let me know, because my mother was unconscious. And they said, oh, we can't tell you that. We can't tell you that. We can't tell you, just give your mother this thing. And I was like, no, that's not going to happen. Eventually, I forced them to tell me the prescription. And guess what? It was a prescription that my mother was allergic to. So I went to another doctor and I asked him, I said, why is it that people don't tell us about their prescriptions and you just tell patients, take this, take this, and that's it. And if they're asking what is it for, you don't tell them. They say, oh, because if you tell them, they'll go and be buying it from the pharmacy themselves and all that kind of stuff. I don't get this. And I want us to talk about this. Dr. Ochasi, what is the medical ethics? What is the policy around this? Should doctors explain to the patients the medication they are giving them, the treatment they are giving them, their cost of treatment? I think I can see it here. It's one of the rights here that the patients have. But why is it not practiced here? How is it practiced in the United States, and what's going on here in Nigeria?
Thank you, Father, for the question. I think it also boils down again to what I said. The culture of medicine in Nigeria is still paternalistic, right? The doctor still believes, well, I know it all. I am the doctor. I don't trust you. You're not informed enough to just keep coming back to me. I'm worried that you're going to run out to the pharmacy and then, refill this prescription without my consent. It's still paternalistic. We need to be able to or trust our patients, that the patients will do what is best, themselves. That's number one. Number two, the second the consideration might be money. Right? It could be, well, I want you to keep coming back to me, to this hospital, so that I will keep getting money by refilling this prescription for you. Okay. Number three, consent is super essential. One of the bedrocks of medical ethics is, being able to give your patients the information they need to make up their mind. If that is lacking, then something is fundamentally wrong. Okay. And consent is not any kind of consent, it is informed consent. Okay, the role of a physician is to give the patient all the information out there, full disclosure, the good, the bad, and the ugly. The second role of the physician will be making sure that the patient comprehends that information, patient comprehension. And then usually we'll use what we call the playback strategy. Tell the patient, in your own words, say back to me what you heard me say. And then the third one is the patient's decision. The patient would say, "Thank you, doctor. I heard what you say. I'm going to pick a second opinion, or I will go with what you have just said." So if these things are lacking, it's still a betrayal of that fiduciary responsibility that doctors have for their patients. So think of doctor-patient relationship as built on trust. It's a relationship. It's a two-way street. You play your role as a physician, and then let me, play my role as a doctor. If you keep thinking that the patient doesn't know what to say or what to do, then it's still paternalism, which is really, really wrong in medical ethics.
Okay, thank you, Dr. Otase. I go to Dr. Njide. I always come to you because you are the bridge. You were once in Nigeria, you are now in the United States. When you were in Nigeria, did you experience this issue of doctors writing prescription and not disclosing to the patients and saying, oh, the patients will go and buy it from the pharmacy and all that and all that? And what is the practice? You're also a doctor in the United States today. What is the practice here? What do you do with your patients? Do you tell them their prescription? Do you explain it to them? Are you worried that they can go and buy the prescription themselves? What should be the standard?
Yeah, so when I practice in Nigeria, and this is something that is ongoing now because I also travel a lot. I have a house in Nigeria. I go back and forth. I do medical missions in Nigeria. The practice is that we just, you hand the medication to the patient. That's what, and you tell them what you're giving them. But for the most part, a lot of the patients don't even understand what the medications you're saying, you're giving them, what they are for. Secondly, and that's a big problem because a lot of times we're writing the medication in plastic, by the time and there's a heat, by the time they get out, you're using a pen to write it on those plastic dispensers, not what we use here in the United States that actually protects the integrity of the medication. So sometimes when you handwrite, it's not very clear. By the time they get home, they probably don't understand. But I remember that, in Nigeria, that's what we use a lot in many of the hospitals. The question of buy medication when you give a prescription to a patient is the fact that there in Nigeria, anybody can walk into any pharmacy and buy a medication. And a lot of times people don't want to come back for follow-up because they think it's going to cost them more money. And they might continue taking a medicine without properly checking and being monitored. So I think that's when I talk to my colleagues who practice right now in Nigeria, that is one of the reasons why they tell the patient to come back, and they're not telling them that they feel the patient will go there, keep purchasing the medicine, and that may not be the right thing to do, because sometimes when you're placed on a medication, you have to come back and you have to check some blood levels or check, even if it's like a blood pressure medicine, they want to make sure that this is working and this is not working, but many Nigerians can just go to any pharmacy and get any medicine they want. In the United States, very, very different. Why is it different? Because prescription medications are regulated. You can only buy certain things over the counter. That's the way we call it. So you can walk into a pharmacy, but there are certain things like paracetamol, you can get that, over the counter. Here, a lot of people can get medications like that, but medicines for certain diseases like treating blood pressure, diabetes, and things like that, you have to have a doctor's prescription. But we know that in Nigeria, that's not the case. So anyone can walk in and get medicine and buy whatever they want. And once they start buying it and something happens to them, again, the enforcement, the issue of negligence, not being able to take care of the patient properly, being blamed, comes back. That patient was seen by this doctor and they gave them this medicine, and you know, the doctor can get into trouble. So I think it's a catch-22, you know. I mean, there are going to be some bad players who say, okay, I'm not going to tell you so that you keep coming back here, you know, to me, so that I can keep making money. But for the most part, I don't think that most physicians in Nigeria, are practicing because of the money, you know, the fact that it's just that they want the person to come back. It's because they feel that the patient does not have enough, cannot make the decision that is that paternalistic attitude and approach to the practice of medicine in Nigeria. I'm the person who knows the best. I'm the person who should make that decision. It should really be an informed consent, like Dr. Chassis said. You giving that information to the patient, two of you coming up with a plan of care, and then you giving that information again. Now, with technology now, this can easily be solved, because if you see someone, you know, and you put that information in the computer, then that information is there. We can know what was given to that person. It matters a lot. Like Father Godzu was saying, a physician wanted to give his mother medication that she was allergic to. If he hadn't found out what it was, that could have been disastrous for him. And I know people who have died because of that. So it's really important that we're sharing that information of what we're giving to family members, to the patient, and allowing them to make a decision as to whether this is something that they